Thank you. Okay, so the way this was invented was an emergency department physician had been using auscultation and had some bad outcomes where they thought the tube was in the stomach, but it was in the lung. They gave charcoal and both had very serious ramifications from that. So he started doing some research and found that even since 2005, auscultation has been banned in the UK and was replaced by pH testing. So he just went and bought some pH strips and said, this is what we should start using. And then as he was trying to utilize them, he realized his patient population, where people were coming from outside the hospital, they may not be NPO, they may have had various foods or drinks that can discolor or make it difficult to interpret a piece of pH paper. He wasn't getting good results with it. So being an inventor himself, he thought maybe there's a way I could pull that sample into a device. So now it's a closed system of collection. And while I'm pulling it in, I can pull it in behind the paper. So just the liquid itself would change the color of the paper, and it wouldn't encapsulate that paper with bits and pieces or different colors or things like that could be part of that specimen, right? So by doing so, even if you pulled in just straight up milk, you'd still see the color change on there bright because it's pulling in behind it. Eventually, as you pull, it will encapsulate it, but you have a little baby, so you're just gonna need a drop or two to wet that paper. You're not gonna be pulling large samples in because you don't have large tubes, right? So that was kind of how it got invented. He patented it in 2013. It came to market in 2015. In 2017, the Patient Safety Organization out of California had a big contest, and he was awarded first place against 55 products in 13 countries as a patient safety award. So we're a distributorship. We started selling the product and going all to the hospitals with pediatrics and neonates. I'm in the Cleveland area, so immediately Akron Children's went in with it, Cleveland Clinic Children's, Rainbow Babies and Children's, and then Dayton Children's and Toledo Children's and Cincinnati Children's. So as far as your locale, you have a lot of users in this area. But it is a nationwide product now, and that's the basis of it. So if you look at the packaging, that's part of accuracy, right? You want to make sure that pH paper is free from air, light, and humidity, because that can all affect the paper. So each one is individually packaged in a foil pouch. So it has a 2-year out date. If you look at the one, there's two sides. If you look at the one side that has a little barcode or the QR code, you'll see it expires 31/10/26. That's what you're holding in your hand. So these are good for another, year and a half, right? So typically about 2 years. So I think Rebecca ordered some in, and we'll check the expiration date on those, but I bet they're going to be a couple years. All right, so that's a good thing. You don't want to open a package until you're ready to use it. When you do open a package, what's nice is there's only one thing in there, one piece, right? We've taken and added the connectors for the NFIT. So now you don't need to worry about adapters or anything. You get an NFIT enabled syringe attached to the one end, an NFIT enabled NG tube or OG tube and attached to the other end. You utilize the test, and then you disconnect at the connector for the cannula. Any fluid in there is going to be able to put back to the baby, so you're only losing a couple drops right in here, which is a good thing, okay? You do not want to disconnect these because there is no valve, and anything in here would then drop down on your shoes or the floor, and we don't want to do that. So this is disconnected here and thrown away as one piece. Obviously it's not a sharps, but it is a contaminated waste. So however you dispose of that. So I think you'll end up using less fluid than you did when you did pH paper. Okay. So the steps to doing this are on the rigid path sheet. That's your competency checklist. So if we look at that, which I just saw today for the first time, but that's okay. We're going to properly attach the syringe. Okay, properly attach the syringe and pull back 0.5 to 20 mLs. Boy, that's a big difference, right? What you really want to look at is what's the prime volume of your tube. So your prime volume of this tube is probably about 3/4 of a cc, be my guess. You can easily determine that by putting it in water, attaching just a syringe, and pull back until it it reaches your syringe, and then you know what that prime volume is forever and ever, right? It's not gonna change. But I need another half a cc right here. So whatever this comes out to be, if this comes out to 0.75, this is another 0.5, or yes, so it'd be 1 1/4. I would conservatively go to 2 mLs, 2 cc's, okay? A lot of that air you're gonna pull back anyway, so it's not like it's all gonna be accumulating in the stomach. What we wanna do then is pull back to 2 mLs, attach it to your tube. We're gonna push that air. As we do, it clears out what might be in that tube, because we wanna test what's at the tip, not what's in the tube. And also it tends to push the tube tip off of the stomach lining, because that air causes it to flutter a little bit. Now these have multiple ports, so the chance of it actually causing an issue of sucking the stomach lining into one of these holes is greatly diminished from before, when there was only one port at the tip, right? So that makes it nicer too. And then we're just gonna keep our eye on the prize, I like to say. That's this piece of pH paper that's in here. This is a one-time use, so it is pH paper, but the scale's wrapped around it. So that's a nice thing too. You don't have to go looking for and possibly contaminating a reusable container. So as we pull that back, you'll see that color change. You'll actually see the fluid come in and then the color change. Once that color changes, stop. We're not trying to fill the syringe. We're not taking a sample for something else. Once we get that pulled back and the color changes, the test is complete. So if you're in a kind of a darkened environment, you may not be able to read it very well there. You can go ahead and take this off, put your cap, go out to where you can see it, take your time, and take a look at it. So you have about 2 to 3 minutes. I think our IFU might say 3 minutes, your paper says 2. In any case, I've seen these last for 3 days and they don't change any color, but we had to come up with what the FDA would accept, and they say read it immediately. So what do you say immediate is? 2 to 3 minutes, okay? There's no reason to wait any longer anyway, because you're checking the placement of that tube before you use it. So that's the simplicity, okay? The thing is, what if you don't get aspirate, right? A test without a sample it's not a test, it's just a piece of plastic. So in those little papers I gave you are some little tricks and tips that they've taught us. And then the main one is, if you don't get aspirate, it's usually one of 2 reasons. The tip isn't in the fluid, right? Or the fluid's very viscous and it's hard to pull it back through. That's where the larger syringe comes in. So if the tip's not in the fluid, that can be addressed if the tip is actually in the stomach by just rolling that patient on their left side. If you've done that before to try to get aspirate with pH paper, same thing applies. Roll on their left side for 10-15 minutes if they can tolerate it, and then go ahead and try to get aspirate back. If you're pulling and pulling and pulling, you're not getting anything back, I have seen where it's a little bit viscous. So what they do is they take a larger syringe, I'll say just no reason to waste it, and just pull back maybe 10 mLs and just wait. And it'll slowly start to migrate like syrup on a cold morning coming down through. And within a minute or so, you'll look over and you'll see that color has changed. And maybe even some is starting to got into the syringe, but that's okay, you have your answer. And that's what you're looking for, right? So those are the tricks. I'm guessing PPIs and H2 blockers are not used here, or are they? Any type of acid suppression medication?
Well, yeah, we do, yeah.
Okay.
Mm-hmm.
So if that's in fact the case, then you want to wait about 2 hours after you've administered. So if you were going to check the tube because you weren't quite certain that the tip is in the stomach, you would probably want to check before you gave that medication. But if in fact you had to wait, you had to test, you would wait about 2 hours. And those are on the sheets also. So after a bolus feed, you wait about an hour. After a PPI or H2 blocker, you wait about 2 hours. And if they are in a continuous feed, you want to turn off the feed, flush with air, the same amount we normally would. Wait about 20 to 30 minutes, and then go ahead and run the test just as we described it. Okay. So I have a handout here, or an illustration of why you don't get aspirate sometimes. The esophagus ends at the lower esophageal junction here, esophageal gastric junction. It is a pinch point, there's a sphincter. If the tube goes and curls up here, you're probably not gonna get anything, or you might get some saliva or formula, okay? If the tube goes in and it's sitting in the in the liquid, probably gonna get a specimen, right? That makes sense. Sometimes it can go up and come up around and be near the top of the stomach if the patient's in certain positions and not in the fluid. That's why that rolling them on their left side tends to work very well. The pocket's over here, okay? So it gives you an opportunity to get the fluid collected. So sometimes a lack of a specimen may mean that you're stuck up here. And we've noticed in experiences we've seen is coughing, choking, gagging, retching, vomiting, or even incessant crying. If you look, the diaphragm is across. So this is below the diaphragm. So that force, if the tube was just inserted just below the junction, could come up a little bit, and it's not going to want to drop right back down. Right? It's going to maybe stay there, and that could lead to some of that issue. All right. Because I have 2 young granddaughters, I have to feature their art. My one that's she was 8 years old, and she said, "Can I try to reproduce that?" And she did that for me.
That's really good.
And then the 4-year-old decided she wanted to try. And she came up with this. And if you
Pickle
look,
in the stomach.
she has a little pickle in the stomach. It's just sitting in there.
If I ever
She
provide
told
a
me
pickle.
they made a pickle.
Pretty
So
judgy.
I appreciate them wanting to be medical illustrators at such early in life. Maybe that's their career path. So there's dangers if you over X-ray, so that's why pH is taken off in such a big way for the neonatal population. Extra X-rays have been shown to lead to later life cancers. In fact, just yesterday was a big publication about CT scans, right, causing tens of thousands of later life cancers if you have an overabundance of CT scans, okay? And any radiation isn't good, we know that. What I can kind of give you an illustration here of, we need to talk about what number we're looking for. Were you doing 5.5 and below, or 5 and below?
I think it's 5.5.
Utilize 5.0 or 5.5, with the majority now moving towards 5.5, especially with the RighSpot. It has a little bit better accuracy because of that technology of collecting the sample. But if you look here, 5.5 is right down the middle, so everything over here is acidic. Gastric acid is normally 1.5 to 2. That's why you can have some food, some water, some meds, some blood, some saliva. It will still be less than 5.5 or less, right? It's when you get into breast milk, and water that they're 6, 6.5, and 7. So adding those together, you can kind of get to that upper level quickly with a small stomach. But it does metabolize back down. That's how they determine those hour, half hour, 2 hour weights, because it will metabolize from 6, 6.5 if it's full of milk, down to 5, 5.5 in a relatively short amount of time. It will reacidify. And if it would be in the lung, it would be the 7.0, which is, if you look at your device, quite dark. And it's a far cry from the gold color you're going to be seeing. But 7.0 doesn't mean it's in the lung, right? It could be just a bunch of waters in there. That's also going to be 7.0. It just means it's not confirmative. Okay. So before you leave, and once you do complete it, I'm guessing you can leave, we're going to have each of you run a test. Okay, so bring your device up with you, and we'll kind of talk through some of the talking points that I discussed, and then we'll have you sign the bottom of your competency checklist. I'll countersign it, and you'll be good. Yep.
I'll open it up here. And then you would pull back the amount of air for the tubing, which is about 2.
Mm-hmm.
Connect it onto here.
Good.
And then connect the other side onto here.
Mm-hmm.
Put the air through. And then
What are you looking at right now? When you're looking, what are you looking at? What's in your hand? Any particular spot that you're observing? Keep your eye on the prize.
Oh, yeah.
Yeah, that's where you're looking.
Sorry, I didn't get there yet.
Okay.
And then I start pulling back until I get the drop onto the paper. Is that right there?
Yep, it's almost there.
Almost there. Oh, I see.
There you go.
And then
So it's a
stop them.
distinct
I see, yeah.
and immediate color change.
Very immediate. So
Right.
then the color I would say is less than or equal to 4.5.
Great. That's what it is. So when you're done, we don't push back through.
Okay.
Any fluid collected in the syringe, we don't push back.
Okay.
Okay?
So then you disconnect the whole thing
Yep. Recap
and then dispose
and
in
then
the sharps.
dispose. You got it. Great.